Ascites is accumulation of fluid in the peritoneal cavity. It can originate from hepatic, cardiac, renal, malignant, and infectious diseases. Liver cirrhosis is the most common cause in adults, especially in developing countries, followed by malignancy, which is followed by heart failure, tuberculosis, and pancreatitis, respectively. Let's see the diagnostic workup in patients with ascites. The initial evaluation of a patient with ascites should include history, physical examination, abdominal ultrasound, and the laboratory assessment of liver function, renal function, serum and the urine electrolyte, as well as analysis of ascitic fluid. On history, patient with ascites should be questioned about the pattern of body weight, the pattern the body weight changed, change in abdominal girth, and edema. Information about the medical history, medication use, lifestyle, risk factors for liver disease, and infectious disease risk are relevant to discover the underlying etiology. A screening physical exam should be carried out in every patient with awareness of signs of liver disease, heart failure, and malignancy. The abdomen should be inspected for the presence of bulging flanks and percussion, which can reveal flank dullness. Flank dullness is found when approximately 1,500 ml of ascites is present. Shifting dullness is determined by a 3 cm flank dullness shift when the patient changes from supine to a lateral decubitus position. Complications associated with ascites such as umbilical, inguinal, and other hernias and pleural fluid are particularly common in cirrhotic patients. So we should have to check for the presence of those complications, check for fluid retrieval, shifting dullness, and flank fullness. When we came to laboratory test, it is recommended to assess serum levels of complete blood count, a count of red and the white blood cell and the platelet, renal function test, electrolyte, coagulation profile, and the liver function test. Abdominal ultrasound is the first line imaging method to confirm the presence and the quantity of ascites. Additionally, ultrasound can provide crucial information about the cause of ascites. It detects signs of portal hypertension and offers guidance during paracentesis. The other most important investigation is ascitic fluid analysis. Visual inspection of the ascitic fluid can show a milky, cloudy, bloody, straw-colored or clear appearance. Milky ascites suggests the presence of chylomicrons containing predominantly triglycerides and is therefore called chylous ascites. Chylous ascites can result from malignancy, trauma, liver cirrhosis, infection, pancreatitis, and congenital disease, and the more uncommon causes. Cloudy ascites, also known as pseudochylous ascites, may indicate peritonitis, pancreatitis, or perforated bowel. Bloody ascites is often associated with malignancy or result from traumatic paracentesis, whereas straw-colored or clear ascites is common in liver cirrhosis. From ascitic fluid analysis, serum ascites albumin gradient is the most sensitive marker to distinguish between ascites due to portal hypertension and other causes, with an accuracy of 97%. The serum ascites albumin gradient is obtained by subtracting the level of albumin in the ascitic fluid from that in the serum. Both should be measured at the same time. A value greater than or equal to 1.1 gram per dl indicates underlying portal hypertension or hepatic congestion. A value less than 1.1 gram per dl indicates etiology not due to portal hypertension, such as malignancy, pancreatitis, or infection. This phenomena, or serum ascitic albumin gradient, is the result of Stirling forces between the fluid of the circulatory system and ascitic fluid. Under normal circumstances, the SAG is less than 1.1 gram per dl because serum oncotic pressure or pulling fluid back into the circulation is exactly counterbalanced by serum hydrostatic pressure, which pushes fluid out of circulatory system. The increase in hydrostatic pressure causes more fluid to leave the circulation into the peritoneal space. The sag subsequently increases because there is more free fluid leaving the circulation, concentrating the serum albumin. The albumin does not move across membrane spaces easily because it is a large molecule. So, if the serum ascite albumin gradient is greater than or equal to 1.1, it is due to portal hypertension, because that is only due to hydrostatic pressure difference. If sag is greater than or equal to 1.1 and ascitic protein is less than 2.5, that's due to cirrhosis. And if sag is greater than or equal to 1.1 and the ascitic protein is greater than 2.5, it is post-sinusoidal. It can be from cardiac and body carry syndrome. A rare cause of ascites with elevated sag and without change in hydrostatic and osmotic pressure is urinary bladder rupture with leakage of urine into the peritoneal cavity. The other is amylase, the amylase concentration in ascitic fluid, which should be measured in a particular case when pancreatic disease is considered. Pancreatic ascites can be caused by leakage from pancreatic pseudocystis or due to pancreatic duct rupture. An amylase ascitic fluid or blood serum concentration ratio of 6 is indicative for pancreatic disease, considering that a ratio of 0.4 is normal in non-pancreatic ascites. However, high levels of amylase have also been detected in patients with malignancy and other condition mimicking, which makes it rather non-specific finding. The other is triglycerides in ascitic fluid. A concentration of triglycerides in ascitic fluid that exceeds the serum level indicates chylous ascites. So if a concentration of triglycerides in ascitic fluid is greater than serum, it is chylous ascites. Previous abdominal surgery, pancreatitis, trauma, and retroperitoneal lymphoma are among the main causes of raised triglycerides. Malignancy is diagnosed in 80% of patients with chylous ascites. The other is adenosine deaminase activity. The activity of adenosine deaminase, which is an enzyme of purine metabolism, is a reliable marker to differentiate tuberculous ascites from other etiologies. Adenosine deaminase activity cutoff value between 36 to 40 has a high sensitivity and specificity for diagnosing abdominal TB. The other is glucose and lactate dehydrogenase. A low glucose concentration in ascitic fluid than in blood serum can indicate the presence of bacteria, white blood cell, or cancer cells. A low level of lactate dehydrogenase is associated with non-malignant ascites, and high levels suggest a malignant etiology. Unfortunately, both measurements are influenced by the serum ascitic albumin gradient, which are non-specific and are no longer recommended. A very uncommon cause of ascites is urinary leakage into the peritoneal cavity. This is common in congenital ascites. Urinary ascites is associated with pathologic bladder changes and outlet obstruction. Normally, the ascites to plasma creatinine ratio is approximately 1, whereas a ratio of 5 is seen in case of urinary ascites. Importantly, urinary ascites can be accompanied by pseudorenal failure due to peritoneal reabsorption of urea. Polymorphonicular neutrophil count should be performed in the ascitic fluid of all patients with ascites, those who are admitted to hospital or showing clinical signs suggestive of SCBP. A polymorphonicular leukocyte count greater than or equal to 250 cells confirms the diagnosis of SCBP in the absence of evident intra-abdominal source of infection. A polymorphonicular count repeated after 48 hours of antibiotic administration can distinguish between spontaneous bacterial peritonitis and the secondary bacterial peritonitis. If there is a decrease, it suggests SCBP, and sustained increase in polymorphonicular count suggests secondary bacterial peritonitis. Spontaneous bacterial peritonitis is a type of ascites infection, while secondary bacterial peritonitis is a type of infected ascitic fluid. The main difference between the two is that SPP doesn't have surgical treatable cause, while secondary bacterial peritonitis does. Although SPP is commonly or mainly a complication of ascites due to portal hypertension, it may also develop in patients with ascites of other etiologies. Ascitic fluid should be cultured if SCBP is clinically suspected. Culture should be carried out before antibiotic treatment is initiated. There is PCR bacterial DNA of Mycobacterium tuberculosis. Bacterial DNA of tuberculosis in ascitic fluid can be detected using PCR and can be performed when tuberculous ascites is suspected. This method has a high sensitivity compared with microscopic AFB and even the culture. There is cytology. Ascitic fluid cytology should be performed in case of suspicion of malignant ascites or when the underlying etiology is in doubt. For example, if there is no decrease in polymorphonicular count after 48 hours of antibiotic treatment. In this case, we consider secondary bacterial peritonitis, so ascitic fluid cytology should be sent. Clearly, positive cytology is highly indicative for peritoneal carcinomatosis. If the conventional workup fails to disclose the cause of ascites, laparoscopy should be considered. Laparoscopy offers the advantage of visual inspection of the peritoneal cavity in combination with the ability to obtain targeted biopsy for histological and microbial studies. The procedure might be particularly helpful to diagnose peritoneal carcinomatosis, tuberculosis peritonitis, and other peritoneal or omental diseases such as mesothelioma and sclerosing peritonitis. Thank you for watching.